say hello and send a very warm welcome to all the people listening at their screens in their home offices and hospitals. Unfortunately, we can't meet each other this year, but I'd like to take the opportunity to thank the organizers for the invitation to give a talk on post-discharge nutrition of preterm infants. So first of all, what are the challenges for preterm infants at discharge? As a consequence of prematurity, these infants generally have limited nutrient reserves since they have not been able to take advantage of crucial last trimester, third trimester of pregnancy. This is a period during which there is transfer and accumulation of nutrients from the mother to the fetus associated with rapid growth. So preterm infants have a high need for nutrients on the one hand and the organ immaturity on the other hand, which contributes to difficulty of achieving dietary intakes that can allow these infants to have adequate growth. They are also at high risk for feeding problems, including a delayed development of feeding skills, like you can see here now. You can see here a preterm infant around discharge, and he's much sleepier than a term infant, have difficulties in latching, sucking and swallowing coordination. Additionally, the preterm population is extraordinarily diversified, encompassing babies with persistent morbidities, for example, chronic lung disease and short bowel syndrome. These infants have high nutritional requirements and or the need to limit the volume of feeds consumed. Finally, preterm infants tend to be discharged before hospital earlier than the expected term. In 2006, the ASPIGAN published recommendations for post-discharge nutrition and distinguished between 4 postnatal or rather post-discharge growth pattern. Here on the slide, you can see the first growth pattern for adequate growth. That means that the infant is born above the 10th percentile and discharged above the 10th percentile. Second growth pattern is catch-up growth. Infant is born below the 10th percentile, and during the course in the neonatal intensive care unit, infant has catch-up growth and is discharged above the 10th percentile. The third growth pattern is extrauterine growth retardation. This is very common in infants with a very complicated neonatal course during their stay in the neonatal intensive care unit. So infant is born above the 10th percentile and then crosses the percentiles either by 2 percentiles or it is discharged below the 10th percentile. The fourth growth pattern is no catch-up growth. Infant is born below the 10th percentile and discharged below the 10th percentile. So who needs a higher density of nutrients after discharge? So at discharge, you have 2 patterns. You have the appropriate growth corresponding group 1 and 2, as you've seen before. These infants are discharged above the 10th percentile. And you have the second pattern. These are the infants who need catch-up growth. They are discharged below the 10th percentile, and this corresponds to pattern 3 and 4 you've seen before. And then we have 2 possibilities. We can either feed fortified breast milk or post-discharge formula. And in infants with appropriate growth, we feed these formulas or fortified breast milk until term. And in infants with the need for catch-up growth, we feed these enhanced nutrients up to the 52nd week of gestation, which is the corresponding 3rd month corrected for term. What are the nutritional requirements, the special nutritional requirements of preterm infants? Well, preterm infants have a higher need for energy, protein, iron, but also for long-chain polyunsaturated fatty acids, zinc, calcium, selenium, but unfortunately no specific recommendations are available for the post-discharge area. This table shows you the nutritional requirements for selected nutrients for the stable growing preterm infant, and you can see that they have much higher requirements than term infants. If you estimate a minimal daily intake of 140 ml per kilogram Breast milk alone, you can see it here in the first column, breast milk alone can't cover these requirements. So breast milk needs to be fortified. You can see the selected nutritional values here. If you do 50% fortification, you can nicely meet the requirements of the discharged preterm infants. If the mother decided not to breastfeed or is not able to breastfeed, then post-discharge formula are available. The nutritional content is lower than in preterm formula, but higher than in starter formulas that you can see here. So it's somehow in between preterm formula and starter formula, and these are the special formulas for discharge. How long should we provide a higher density of nutrients by fortification or discharge formula? There are a lot of studies that show that providing a higher density of nutrients until term induced catch-up growth and also induced a better new developmental outcome. But how is the evidence after term? There are only a few high-quality studies that summarized by this Cochrane review, including only 256 infants. The trials differed slightly in the mechanics of delivering the multi-nutrient fortifier. Here in the first study by O'Connell, published in 2008, infants received fortifier in about half of their daily intake of breast milk, whereas in the second study, the Zacharassian study, published in 2011, the fortifier was given only once daily, mixed up in 20 to 50 ml of milk. In both trials, the remaining feeds were either taken directly from the breast or as an unfortified expressed breast milk ad libitum. The intervention was done for 12 weeks in both studies. Meta-analysis of data from both trials did not find any statistical significant difference in growth parameters at 3 or 4 months of corrected age. You can see here the data for weight. And they did also find no statistical significant difference or head circumference or length at 12 months of corrected age. You can see this here. So no difference in this weight data. However, several studies have shown some other advantages of the use of human milk fortification after discharge, such as better lung functions at 6 years, better anthropometric parameters in the special group of preterms with a birth weight below of 1,250 grams up to 1 year of life, and a better visual function. What about early diet and long-term neurodevelopmental outcome? This is a follow-up study of preterm-born children who are randomized at 36-week corrected age to either preterm formula, you can see this here, or term formula, or a crossover group. The crossover group received preterm formula until term and afterwards term formula. And the intervention was done for 6 months, and childhood cognition was assessed using the short form of Wechsler Intelligence Scale for children, allowing computation of full-scale intelligence quotient. You can see it in the first line here, and the sub-items of verbal comprehension, freedom from distractibility, perceptual organization, and processing speed. Overall, the mean intelligence quotient was -7 points below the standard mean scores for term infants. But it was not shown that there was any correlation between the formula with the higher nutritional content or the cognition outcome with 10 years. Importantly, the authors showed a strong association of early infant growth and later cognition. You can see it here. Here are the same items from the Wechsler Intelligence test. And the association, there was multivariate association of growth with cognitive ability. And what you can see here, that the infants who were growing better had a higher intelligence than the one with the lower growth. So there is a correlation, not between enhanced nutrients, but between growth and later cognitive outcome at 10 years. But there is a second issue that we call the breastfeeding paradoxon. This study assessed the relationship between breastfeeding at the time of discharge, weight gain during hospitalization, and neurodevelopmental outcome. You can see here two large cohorts. This is the lift cohort with 1,733 former preterm infants, and the equipage cohort with 2,163 preterm infants. And breastfeeding at the time of discharge was 16 to 19%. You can see the breastfed infants here in these black dots and lines, and the formula-fed ones with the gray dots and lines. And breastfeeding was significantly associated with an increased risk of losing one weight set score during hospitalization. This was here, especially here. But the infants had a higher head circumference set scores at 0.5 and 2 years in the lift cohort. You can see this here, and also with 5 years in the equipage cohort. So that means that breastfed infants do not grow that well during their stay in the neonatal intensive care unit, but afterwards they have a better growth, especially in head circumference. And there is also a correlation between neurodevelopmental outcome and breastfeeding, which you can see here. These are infants that were not breastfed, of course, in their neonatal intensive care unit. And these were infants who were breast up to discharge, up to 2 months, and after 2 months. And what you can see that this is a nice correlation between the duration of breastfeeding and the later outcome measured by the Kaufman assessment developmental testing. What about the introduction of complementary food? The European Food and Safety Authority says that the right time point of introducing complementary feeding is to anatomical changes in the oral cavity, disappearance or diminishing of reflexes present at birth that coordinate sucking, swallowing, and respiration, and protect the infant from aspiration and choking, and the development of gross motor skills, especially the head and trunk control, to allow an improved movement of the jaw and fine motor skills. Most data regarding complementary feeding in preterm infants are reported in a few observational trials, which the one you can see here by Silvia Faranov. This is an Italian study, but most of these studies were conducted before 2000 under different circumstances. And despite the wide variability in timing and quality of complementary feeding, the available studies document that preterm infants are introduced very early to solid foods. This is a survey where they distinguished between very small preterm infants born between 24 and 32 weeks and late preterm infants. And what you can see here is that the younger the infants were, the earlier solid food was introduced in this observational study. And this is also introduction of solids was also related to birth weight. The smallest infant with a birth weight below 1,000 grams were the ones that received solids very early, around the 13th week, corrected for age, which corresponds to 3rd month. And introduction of solid was also related to breast milk feeding or formula feeding. Formula-fed infants were introduced much earlier with solids than breastfed infants. What is the type of complementary food in preterm infants? It's more or less the same like in term infants. Usually parents start with fresh fruits and vegetables, then followed by cereals, meat, milk products, fish around 7 months, eggs around 8 to 9 months, and salt and sugar after the first year of life. What about prospective randomized controlled trial? There is only one high-quality randomized controlled trial conducted in India, and this trial was conducted in mostly large preterm infants with a gestational age around 32 weeks and a birth weight around 1,500 grams. And primary outcome of this study was set scores in weight with 1 year of age. And you can see here in the blue line, the solids were introduced at 4 months of age, and in the red line, the solids were introduced at 6 months of age, and there was absolutely no difference in outcome, in weight, in anthropometric outcome, weight set scores with 1 year. It is remarkable that there's an inevitable loss in Z-scores during the stay in the neonatal intensive care unit and up to term, approximately about minus 2.8 minus in Z-score, and with 1 year still minus 1.6 in Z-score, which is really remarkable. I'd like to present you unpublished data from my own group. We did a prospective randomized controlled trial where we introduced early complementary feeding in preterm infants between the 10th and 12th week of gestation, or in the late group between 16 and 18 week of gestation. And the infants had to adhere to an absolutely standardized diet. They received feeding boxes from us with fruits, vegetables, cereals, and they had to strictly adhere only to this diet and were not allowed to eat anything else. So our patients had a mean gestational age about around 27 weeks of gestation, and their mean birth weight was around 950 grams in both groups, so they were much smaller than the infants in the Indian trial. And our primary outcome was length with 1 year, and you can see here with the red lines the early group, and with the blue lines the late group. And here the Z-scores for weight and length, and you can see in primary outcome absolutely no difference between early and late introduction of solids between two groups. We had a slightly difference in Z-scores in weight at 6th month, but this was not consistent. And here are the data for head circumference, no difference, and also for BMI. And you can see here also that our drop in Z-scores was at a maximum of 0.2, and this is also a difference to the Indian study where we had much larger drops in Z-scores. What about feeding problems and eating behavior? A remarkable number of infants preterm infants have problems with eating behavior. This is related to their intrinsic immaturity, neurological deficits, comorbidities, and also to unpleasant procedure the infants had to undergo during their hospitalization, for example, tube feeding or intubation. A remarkable group of infants are discharged on tube feeding. 15 to 23% of the infants born below 29 weeks of gestation are discharged on tube feeding. And concerning the feeding problems, this is a study where questionnaires were sent out to parents of early and late preterm infants at, as you can see here, the early group and the late group at 3, 6, and 12 months. And the parents were asked for perception of infants' feeding skills, comfort with feeding, hospital visits for feeding difficulties, what were their observations. And what the authors found that preterm infants, and especially the smaller ones, had a consistent problem with oromotor dysfunction during the first year of life. You can see it here in this group. And also during the first 3 months, problems with avoidant behavior of bottle or breast or solids. So to summarize, what are the recent challenges in post-discharge nutrition? On the one hand, we have the post-discharge nutrition with the breastfeeding paradoxon, the advantages of the use of human milk, the fortification possibility after discharge, and the challenges are to define entity and velocity of catch-up growth, what is the right catch-up growth, to individualize the nutritional approach, to define the nutritional requirements of the discharge period, and to consider the feeding skills and emotional factors of parents and preterm infants. And during the weaning time, where solids are introduced, we have here this growth standards up to 52 to 64 weeks postmenstrual age, and the weaning period between 4 and 6 months. And the challenges are again to avoid the risk of postnatal growth deviation, to individualize the nutritional approach, to consider feeding scale and emotional factors of infants and parents, and to consider the acceptance of semi-solid foods and micronutrient intake. So to conclude, the available data suggests that there is no specific timing which applies safely to all the preterm infants concerning introduction of solids, who constitutes an extremely variable population in terms of achievement of developmental milestones and oral skills. For this reason, we propose that complementary feeding in preterm infants should be introduced following an individualized evaluation, mainly based on the infant's development rather than corrected or postnatal age. And I'd like to finish my talk with this nice little guy and the successful introduction of solids, and thank you for your attention.